So,
Dr.
Yeah, hi, Dr. Agam.
Hi.
Hi, sir.
Oh, Dr. Vora himself.
Perfect. 2:30. I'm there.
Yes, sir.
શું કહો છો કેતનભાઈ? ક્યાં પહોંચી ગયા?
All fine. ઘરે આવ્યા?
Good. કોણ કોણ? ગુલશન, મનીષ વર્મા, લેલે સર. વાહ ભાઈ વાહ.
Yeah. So, sir, I'll just quickly take you through the flow. So, Dr. Lele, you will be introducing the speakers.
Yeah. There is a Dr. Lakshmi Mehta, our president, will also join. We'll just check why she has not joined. She must have joined from the. I'll just check.
Sure.
Sir, you have Dr. Ketan Mehta and Dr. Vora's profile.
Yeah, we have got that. Now everything has been set.
Manish, just to let you know, every morning, myself, Dr. Lele sir and Dr. Agam Vora, we have coffee together.
And we only discuss about your CME program. हम खाली इसके बारे में बात करते रहते हैं.
So, virtual coffee every day you have together.
So,
first, Dr. Ketan, now you will be starting the presentation. First, you will present.
No, I have got an order from the Supremo, Dr. Vora, that he would talk first. So I have to follow the instruction.
I'm so happy. I'm loving this. Lele sir कहाँ busy हो गए?
I think he's waiting for
somebody to someone else who has to join in.
अच्छा और कौन गया?
Rashmi, for welcome.
So आज भी attendance अच्छी है sir. Already we have 600.
See, Dr. Vora's charisma.
People join.
Well. I like this credit. मुझे अच्छा लगता है केतन सब काम करे और मुझे क्रेडिट मिलती रहे. Perfect arrangement.
Please join.
कि मुझे क्यों नहीं दिख रहा है? गुलशन को दिख रहा है.
कहाँ पे? आगे.
मुझे तो दिख ही नहीं रहा अभी.
अभी सर उनका वीडियो ऑन नहीं है इसलिए नहीं दिख रहा.
उनका वीडियो ऑन नहीं है.
IMA मुंबई वेस्ट के नाम से शायद ज्वाइन किया है.
Everybody is waiting for Rashmi. Rashmi is here finally.
She's put on her video now.
Yeah.
Adjust your camera.
Yeah. Rashmi, welcome.
Good afternoon.
Good afternoon, Dr. Rashmi.
मैं संभला था ना थी.
Microphone. You're not audible.
Mic is not adjusted well.
Ma'am, now the mic is on mute.
No, ma'am, we can't hear.
Maybe you can just leave once and join again. There is sometimes this problem. You can leave once and join again, वो ठीक हो जाएगा.
Tavish is from the technical team?
From our technical team, sir.
Yes, sir.
Okay. And the sponsor team, not there?
The sponsor team is not there, sir. So this is like they don't want to be आजकल कंपनीज में भी रेगुलेशंस आ गए हैं बहुत से, उनको भी बहुत ज्यादा डिक्लेरेशंस देना पड़ता है दे कम एंड टेक देयर नेम्स.
अच्छा, so इतनी secrecy.
हाँ, so it's like it is being done by DRL, sir. It's being done on behalf of DRL. But if they come, then another paperwork trail needs to be
A lot of
sorted out.
paperwork has to be done, sir.
Last time अच्छा ग्लेनमार्क का किया था तब तो हाँ they were coming, but we did another program, international program for Ciplas Euro. And it was a big program, 5 international KOLs and 10 Indian KOLs over a period of 3 months. उसमें they never even said Cipla पूरे program में.
Glenmark wala was way before these regulations came in actually, Dr. Manish.
Okay, fine. Sir, what about
Dr.
MP
Rashmi?
and HSG joining?
No, this is not. This is I am a Mumbai-based Ketan.
Oh, okay.
Over to you, Rashmi. You can start.
You're not audible, ma'am. Dr. Lily, can you just give me her number? I'll just speak to her and sort it out.
Yeah, 98200
98200
08796.
Sure.
Sunita has come, so it will be done now.
It's usually always a small click here and there and it happens.
सर ने तो लाइव डेमो दे दिया, खांसी हो रही है.
Thank God it's not a gastro program.
Rashmi, you can join from the mobile.
Yes, here there are 2 laptops there in the office.
કેતન કોઈને વિઝિટ મોકલવું હોય ઘરે તો તું કોને મોકલાવે?
પ્રહલાદ.
ઓકે.
અને સ્પેસિફિકેશન જોતું હોય એમડી તો પછી દેવવ્રત.
ગયા છો નહીં ઘરે?
गुलशन को भी खांसी हो गई.
She demonstrating hydration is a good therapy for dry cough.
Okay.
So she has some system issue.
Rashmi, you can just join from the mobile.
Try that one.
She is fine.
बघा आता विचार.
बघितलं बरोबर आहे.
विचार. Can you hear me now?
Now you're audible. Tavish, just get ready to stream.
Am I audible?
Yeah, you're audible.
Am I audible?
Yeah, you're audible.
इथे नाही, इथे करा म्हणून तुम्ही तिकडे बघा. Now the issue is the people who are going to introduce are not in this speaker, this thing. Will they be able to speak? There are two people who are going to introduce each of the speakers. And another third person is going to give vote of thanks.
Ma'am, they'll have
No,
to
we'll bring
join
them.
this team.
I will send you a separate link, Rashmi.
Mm.
Through that link, they can join.
Because I send them my link, they are not able to join because they're saying they have already joined.
No. I'm sending you the separate link.
Okay,
Just
sir.
forward them.
केतन आदे भाविंचा पण एंजियोग्राफी करवा जाय છે સિટી એન્જિયો
हाँ बोलो.
3 જણાને તો મેં
તો બધાને
મોટિવેટ કર્યા છે
કામે
CT
લગાવ. હા.
એ કહું 3 જણાને તો મોટિવેટ કર્યા છે સિટી એન્જિયો કરવા માટે ભાવિન તો આજે જ જાય છે
સૂરજે એ જ દિવસે કર્યું, બપોરના સાંજના જઈને કરી આવ્યો.
ટુ મચ ને
Yeah, I think Rashmi, you start. I'll send you your link on the WhatsApp.
Am I audible?
Yeah, you start.
Good afternoon, everybody.
Good afternoon.
This is Dr. Rashmi Mehta, President, IMA Mumbai West, and I welcome each and every one of you for this interesting webinar on cough update. IMA Mumbai West is always at the forefront of CME activities. It is the leader and has the maximum number of CME programs every year amongst all IMAs, probably anywhere. To give you an example, in the month of June itself, we have 9 CME programs. So we wish to continue keeping the lead, and we have 2 star speakers of our branch who are going to give us inputs on cough. Cough is a signature or a symptom of what is going on in the upper respiratory tract and the lower respiratory tract. And we have experts who are going to guide us into management of this symptom. We also have, just for the information, we have another interesting conference, which is again a hybrid conference on 6th of July. It is called Mahajaricon. It is with IMA Maharashtra State. And I request everyone to register and log in for the same. This is going to be physical also. So those who can attend physically also. For today's conference, we are grateful to past HSG IMA headquarters, Dr. Jayesh Lele sir, who is the trustee of our branch and who has arranged for this interesting webinar. I would request Dr. Jayesh Lele sir to say a few words.
Yeah, to Rashmi, and this is as you mentioned, I think the CME, we are doing a great amount of work last almost persistently for last, I think, I would say about 25 years. And various kind of conferences, be it a national level, state level, and of course the branch level. Maybe it's a health days related conferences, we are doing it. And this is a special series of webinars, 2 webinars we are arranging with the help of Dr. Manish Verma and Spirant. And last year also, 2 years back also, we had done similar webinar, and this time it is going to be none other than very interesting related to the cough. which is, I think for the family physician, every day at least 50% of the patients coming in, walking in with the cough, different types, maybe 8 days, 10 days, 2 days, or whatever it is. And so it forms the very important criteria for having the such a cough this thing. And today we have two stalwarts from our own branch, Dr. Ketan Mehta and Dr. Agam Vora. And in spite of the various their issues, various their work, overwhelmed, I would say, most of the occupied the CMEs are it is borne by them, and they are always there to help us whenever just call for at a leak of a call. And so today also they have going to talk on the two topics: dry cough and expiratory cough. So I think let us start the CME program without wasting. And of course, I would request everybody, those who are interested, to have the CME point, because this is accredited by the Maharashtra Medical Councils, to put their registration number in the chat box, because without registration numbers, we won't be able to give you the certificate. We will give the e-certificate, but they must put in whatever the charges are there by this, and put it into the chat box, the details, and we'll go ahead with the program. So I think over to you, Rashmi. You can call the speaker, our chairpersons who are going to introduce speakers. Over to you, Dr. Rashmi. Thank you.
Thank you, sir. To introduce the first speaker, Professor Dr. Ketan Mehta, we have Assistant Director CGP, IMA Mumbai West. Ketan, you're muted.
Agam will be taking the first talk.
I see.
Yeah, that is the instruction from the boss.
Okay. Then I would like to invite, she has not yet joined, Dr. Pranita.
Oh, she has joined. She has joined, Rashmi. She has joined.
So I would like to invite Assistant Secretary CGP, Dr. Pranita Bhatte Varlikar, to introduce our first speaker, Dr. Agam Vora. Dr. Pranita.
Hello, can you hear me?
Yes, yes, we can hear you. Madam, please go ahead, introduce Dr. Agam Vora.
Professor Dr. Agam Vora is a renowned pulmonologist, especially known for the critical care he offers. He is FCCP USA, FRCP London, FICP and FCCP from India. Dr. Vora manages Brahma Kumari's Global Hospital and Research Center and is also managing BACS MG Hospital at Andheri West. He is ex-assistant honorary Department of Chest and TB, Cooper Hospital, and also ex-assistant professor of Department of Chest and TB, KJ Somaiya Medical College. Requesting Dr. Vora to please commence his talk. Thank you.
Good afternoon, everybody. Thank you, Pamita Madam, for those nice words of introduction. I must thank IMA Mumbai West for giving me this opportunity to be here. Rashmi Ben, thank you very much for being here. Jayesh Lele sir is my mentor, his guide, and my association for more than 2 decades. And of course, my biggest buddy, Dr. Ketan Mehta, is here. And I'm so secured when Ketan is around. If there is any complicated situation, any difficult question that I cannot answer, I have Dr. Ketan Mehta here with me. With those words, it's already spoken about that cough is a common presentation. Trust me, whatever be your specialty, be it a family physician practice, be it a chest practice, be it a consultant practice, ID practice, cardiology practice, gynecology practice, neurology practice, irrespective of your specialty, you're going to see patients with cough. And I was looking at data, it says that every 5th patient walking on the street may be coughing. It may be just one episodic transient cough, or it may be a chronic cough. If you look at specialty clinic, or if you look at family physician's clinic, probably 30% of your patients are because of cough or cough related issues. And if you look at specialty clinic like mine, everybody is coughing when they enter my cabin. I must express my sincere thanks to my teacher, Professor Director Dr. K.C. Mohanty. I must also thank IMA Mumbai West, and of course, I must thank the organizers, Manish Verma and his team, for the excellent platform they've provided. I must thank each one of you. I'm too. Already 800 of you have joined. It's only your presence which encourages us to do more and more program. The agenda that I have in mind for next half an hour or so is to talk about my data, to talk about cough and how we look at cough, talk to you in particular about wet cough, and then end with few common cases that you and me see in practice. I looked at my last 100 patients data, and I was trying to understand what I am seeing. I'm sure most of us would end up seeing similar situation. When I looked at my 100 patients, first 21 is acute cough, about 33 subacute, and remaining 46 were chronic cough. So being a specialist, I see little more of chronic cough, but being family physicians, probably you being the first point of contact, you may end up seeing more of acute cough. And when you look at causes, the common causes with which they present to me, that's upper airway cough syndrome, GRD, or allergy related disease. And when you look at infection domain, you have tuberculosis as a presenting symptom. Trust me, everybody, right from a person on the street to some celebrities like what you see on the screen attending Dr. Ketan Mehta's clinic, may also be suffering from cough. The cough spares nobody. And not only in our kingdom, oh, I think the sound is missing, but across the animal kingdom, you will see cough happening. There's a few of the examples of cough, there are a few of the examples of sneezing, there are a few of the examples of dry cough, there are a few of the examples of wet cough, where you can see some expectoration, some secretions. This video also shows some examples of ineffective cough when the animal is not able to cough well. Across the age group, across be it children, be it adult, or be it geriatric population, you will see them coughing, and you will see them presented to you with this particular cough. And the cough is designed mainly to remove secretions or inhaled particles from your tracheobronchial tree or your pharynx. It is actually under voluntary control, though there are some causes where it is an involuntary reflex. So there are various cough receptors. You have cough receptors which are situated in the alveoli, you have cough receptors which are there in the bronchi, on the pharynx or the larynx, even in the posterior part of the uvula, you have these cough reflexes which are receptors which are there. And these cough receptors get stimuli from either a mechanical or a chemical stimuli, or it can be even thermal stimuli. The message from this goes via vagus, glossopharyngeal, and trigeminal nerve to the medullary and pontine area of midbrain, and which is under the cortical influence. The cortex influences this area, and hence you can actually suppress it. If you're sitting in a meeting or a program like this, your higher cortical influence can actually suppress the cough. But otherwise, it is under medullary and pontine areas, and the message from it comes from vagus, phrenic, and the spinal motor nerve to give you a response or the motor response. So how is the response? What actually happens is there is inspiration of about 2.5 liters of air. So you take that much of air, and then the epiglottis closes. The vocal cords are shut, and the air in the lungs gets trapped. Over time, the abdominal muscles will contract. They contract forcefully and push the diaphragm. The other muscles also contract forcefully, and the pressure in the lung could rise to as high as 100 millimeters of mercury, which is higher than the diastolic blood pressure. So it can go above that, and the cords would suddenly then open. And the air under pressure would be expelled out, and it moves with the velocity as high as 75 to 100 miles an hour. Trust me, it is miles an hour. So Ketan, if we calculate, it would be what? About 120, 130 kilometers an hour, which is a great speed. So with this speed, these secretions come out, clear your airways. And when I was a student, I was told not to treat symptom because cough is a symptom. And you must put all your money on identifying the underlying cause and treat the cause. But we realized during last couple of years that yes, it is important to identify the underlying etiology and treat it. But by the time you do that, by the time your effective treatment starts working, you need to manage the symptoms, because symptoms also have its own set of problems. Like fever, fever per se can give you convulsions, fever per se can give you dehydration, fever per se can give you its own sort of problems. Similar is cough. Cough itself, irrespective of its etiology, has got a lot of issues. It has got physical issues like it can give you syncope, it can give you urinary incontinence, it can deprive you of your sleep. It can give you anxiety, it can give you depression, and it can give you social issues like avoidance on social events. Trust me, cough can have serious complications. If I remember, in last 3 months, I had three young patients who came to me with fractured rib because of cough. We all know that somehow vitamin D levels of our community is less. Our youngsters walk less, they do exercise less, they work most of the times on computers and indoors like this. Their sunlight exposure is poor, pushing them to getting early fractures. And this cough, if the air is moving at this high velocity and if it's generating so much of pressure in the chest, can fracture those ribs. So you can have serious complications. Pneumothorax is the complication. The pneumomediastinum, pneumopericardium, cardiac arrhythmias, loss of consciousness, and syncope could be serious complications of cough. When I look at cough, I like to understand cough under various ways. So one way to understand cough is to classify depending on its duration. So whether it is acute, subacute, or chronic is one way of looking at it. The other way of looking at it could be etiology based, whether it is lung related or the respiratory related, or it could be extra pulmonary cause. The cause could be there in the middle ear. You may have a subdiaphragmatic abscess giving you cough. Or another way of looking at it is productive or dry. The dry part of cough management is going to be dealt by Ketan, and I'm going to focus on productive cough. When you look at acute cough, if you're trying to divide or understand cough based on its duration, anything less than 3 weeks would be acute cough. 3 weeks to 8 weeks is subacute cough, and anything more than 2 months or 8 weeks is called chronic cough. And then there are specific causes for acute cough, subacute cough, and chronic cough. And as I said, it could be respiratory or non-respiratory. This could be a psychological disease. It could be GE reflux. It could be recurrent aspiration, or it could be even drug related. You all are aware that drugs like ramipril or even beta blockers can give you cough. Having said that, if you're looking at chronic cough, if you're looking at cough which is going on for 2 months, and if it is not associated with fever or constitutional symptom, you're talking about by and large only three diseases, and that is one, asthma or allergy related, second, reflux or GERD related, and third, upper airway cough syndrome. By and large, these are the causes. And when you look at wet cough, if you are dividing or looking at cough as dry or wet, the wet cough generally you see in asthma COPD exacerbation, you see it in infections of airways, you see in lung abscess, you see in bronchiectasis, you see in cystic fibrosis, you also see it in cases of pneumonia. Cough, you could also look at ineffective cough or cough with normal X-ray chest, or there is a separate entity called chronic idiopathic cough or cough hypersensitivity syndrome. You may also see cough like if patient is under anesthesia, if patient has got a spinal cord injury, patient has got myasthenia gravis, the patient has got metabolic acidosis, or there is severe pain following surgeries, etc. Patient may have ineffective cough. After having understood what is cough, how does it stimulate, what are the receptors, where are the receptors, what is the actual motor response, and after looking at how we divide cough or how we try to understand the classification of cough, then comes the clinical evaluation. The first thing is to look at the danger signs. There are certain red flag signs. If your patient with cough is suffering from hypotension, loss of consciousness, altered behavior, if there is severe chest pain, if there is hypoxia, if there is hemoptysis, these are the patients to be referred to tertiary care unit and not to be mentioned at our level. But if otherwise, this patient would require thorough investigation. When you're looking at wet cough, try to assess the quantity of cough. Try to look at the thickness, whether it is mucoid, watery, or it is thick, purulent. Look at the color and look at associated tinge, whether it has got any blood tinge. Look at patient's detailed clinical evaluation. Understand the past illnesses that patient has. If patient gives you history of smoking, if patient gives you frequent such episodes in past, elderly patient with exposure to occupational hazards, you know that you're dealing with COPD. If this patient has got allergy in past, if this patient has got similar illness in family, if he has got upper respiratory involvement as well, you know you're dealing with probably asthma exacerbation. Or if it is a seasonal cough, you know it is allergic seasonal cough, pollution related, or if there are cases of COVID going on, if there are cases of flu going on, you know that this would be virus-related exacerbation. Danger signs, I already said, this patient could be present, this could be having pulmonary embolism. This could be pulmonary edema, it could be acute severe asthma, it could be pneumothorax, or it could be foreign body aspiration. Acute type 1 respiratory failure would demand hospitalization and management accordingly. Your clinical presentation would depend on what kind of disease you're dealing with. It may be a common cold, short SNET, it may be a pneumonia with chest pain, you may have bronchial breathing and auscultation, and there may be thick, rusty sputum. Influenza generally is high fever, lot of malaise, body ache. Post-nasal drip patients may have postural change in the cough severity, cough variant asthma. You do their peak flow meter and you will pick up that. You give them salbutamol and give them a course of steroid, you would see the response. Post-infectious cough could go on for a longer time. What investigation? Generally acute cough, generally wet cough, may not require much of investigation. This is generally seasonal. You will get clue from the clinical evaluation and the history that patient gives you. But if it is a chronic cough, you will need to take this patient for series of investigation, a battery of investigation, which may be a simple X-ray chest to sinus X-rays to blood biochemistry to spirometry to maybe even further tests like CT scans. You may even need to do the sleep studies, and you may to do OGD scopes to look at stomach, to look at esophagus, and to confirm the diagnosis of GERD. I like this. Whenever you have a normal X-ray chest and cough going on for a long time, this could be one of the causes. The commonest is drug-induced. Your ACE inhibitors gives you cough. Beta blockers can give you cough, especially the old generation beta blocker, the non-specific beta blockers, propranolol and atenolol group. It may be normal X-ray chest, cough, viral respiratory tract infection. It could be cough variant asthma. It could be GERD. After having dealt with this, let's concentrate on pharmacotherapy. So what treatment would you give them? How is the pharmacotherapy for cough designed? You need to find out what is the underlying etiology. If there is bronchitis going on, you will treat for acute bronchitis and cough to be managed separately. If you're looking at pneumonia, patient would require definitely antibiotics. You have a pneumonia severity index. You have a board score. You will find out whether this patient requires hospitalization, should be managed on OPD basis, and accordingly managed. But having said that, the primary management, we are talking about symptomatic management, and symptomatic management for productive cough would be management of mucus. So mucus can be managed by various ways. There are expectorants available. There are mucolytics available. There are mucus enhancing drugs available. There are demulcents available. So when I look at the treatment for wet cough, pharyngeal demulcents are used, like you have all those lozenges, cough drops, you have menthol, glycerin, honey. All your grandmother-based treatment would help you in probably reducing the throat irritation. And these are very useful for your acute wet cough. They're very useful for irritating cough. It is very useful for seasonal cough. It is very useful for symptomatic relief. When you're talking about mucus management, you have drugs like mucokinetics. Among these mucokinetics, you have first is bronchial secretion enhancers. So you have sodium and potassium citrates and iodides and guaifenesin, etc., which are the molecule which would enhance the bronchial secretion, would make it little more liquidy. It would make it a little more easier for patient to get it out. There would be drug like mucolytics. It breaks the disulfide bond between those thick mucus and makes it again less tenacious. Patient finds it easier to get it out. And you have N-acetylcysteine group of drugs. So you have acetylcysteine, Ambroxol, bromoxine. You have certain drugs which are mucomodulators. So you have drugs like acebrophylline, etc. would be in this group. You have also certain drugs which would be adjuvant. So you have drugs like antihistaminics, you have drugs like bronchodilators. When combined with this particular drug, may have edge in a particular situation. So by and large, it is recommended to use very specific therapy. But there are situations where combination therapy would help. There's a lot of awareness about this irrational combination. When we reviewed this literature and IMA took active part in this particular issue at our level, that is about irrational combination, we realized conventionally there were so many combinations, like you have a cough suppressant and a mucolytic there. So on one way of suppressing this cough, but here you're adding something which would enhance the secretion, it would have antagonistic effect. So I may realize that there are certain drugs which are having antagonistic effect, or there are certain combinations which have got similar side effect profile. So you have drug, say you have a first generation antihistamine which give you sedation, and you have drugs like, for example, codeine preparation that also gives you sedation. When both different molecules having similar side effects are combined, the side effect profile is enhanced, and those preparations are withdrawn. So my idea of showing you this particular presentation is to make you aware that yes, there are certain rational combinations available in market which has approved preparation, which are IMA endorsed preparation, which can be used to reduce pill burden and to improve compliance of the patient. So say you have a patient of COPD, you have a patient of chronic bronchitis getting infective exacerbation. Of course, you would treat this patient with nebulized medicine. Of course, you will treat this patient with oral steroid if required. Of course, you will give this patient antibiotics or antivirals depending on the bacterial or the viral etiology. But for cough, you can combine these patients, you can give these patients a cough, a mucolytic drug or an expectorant drug along with antihistaminic, it would help. You have a patient of bronchitis, a seasonal bronchitis patient who's not on any bronchodilator, and this patient develops wheezy bronchitis. Yes, you would combine a mucolytic with a bronchodilator. So there are this rational preparations available for use which would reduce the pill burden. Allow me to quickly run you through a couple of cases. Look at female 78 years old, non-hypertensive, non-diabetic, a confirmed case of interstitial lung disease, to be specific fibrosing alveolitis for almost 5 years and on home oxygen therapy. This patient presented with 5 to 7 days cough with expectoration, with fever, and this patient had urinary incontinence. Trust me, senior citizens, when they get cough, they have urinary incontinence and disturbed sleep. This patient's cough management was extremely important. X-ray had consolidation. You can see that there is a patch of consolidation here. I don't know whether you'll be able to hear this sound. Hope you're able to hear this sound. This is X-ray. If you look at it's a left low lobe consolidation with bilateral reticulonodular pattern. You can see trachea shifted to right. So there is a volume loss on right side. You see reticulonodular pattern means it is interstitial lung disease, and then there is a consolidation there. This is acute wet cough. This kind of preparation would require a good mucolytic. You could see that there was some wheezing associated, and probably this patient would benefit associated bronchodilator. So you have a combination therapy of mucolytic and bronchodilator could be useful for this patient. In fact, this patient may benefit with a combination of a mucolytic, bronchodilator, and even antihistaminic. Look at this second case, a 25 years old lady, non-hypertensive, non-diabetic, came to you with 2 weeks history of cough. There were crepes on left lower lobe, and you know there's acute cough. This is the presentation. There is a left-sided consolidation, but this is dry cough. This is another case of 65 years old male patient, obese, hypertensive, non-diabetic, 3 weeks cough with wheezing, PFT showing obstruction. You can see this spirometry, it shows definite obstruction. This is a case of COPD. You can see this X-ray, though it is showing mild cardiomegaly. It is a case of COPD. And oh, I'm sorry. This was the case of COPD, and yes, this is the cough. You can see that there's a wheezing sound. That prolonged thing tells you that there is associated wheezing. This patient would benefit, of course, with combination therapy. This patient was on inhaled bronchodilator, and hence I kept this patient on a mucolytic with antihistaminic combination. A last case, 35 years, non-smoker, no major illness, family history of asthma with allergic rhinitis, short onset cough. You know that this lady has bronchial asthma with allergic rhinitis, and this is the cough of asthma with normal X-ray chest. This kind of patient respond with a combination therapy of a bronchodilator and expectorant. To summarize, I would tell you that try to distinguish this cough, whether it is acute or it is chronic. By acute, I mean less than 3 weeks. I think there is a mistake. It has got to be 3 weeks duration, and chronic cough is anything above 8 weeks duration. Chronic cough patient would require definite investigations. You can't treat this patient just symptomatically. You would initiate symptomatic treatment depending on their cough, whether it is dry or wet, whether it's got antihistaminic addition or it requires bronchodilator addition. Meanwhile, you subject them to full-fledged investigation. Therapeutic suppression of cough either is disease specific or symptom related. By the time you diagnose patient having tuberculosis, by the time anti-tuberculosis treatment works, you know that it would take about 7 to 10 days minimum for it to start acting. You will have to treat this cough. If you don't treat this cough, patient would be continue to be symptomatic, number one, and it would continue to spread disease. It is of paramount importance to suppress this cough. Do consider the causal treatment. First of all, put all your money, put all your efforts in identifying the underlying etiology, divert your resources on treating the etiology, and simultaneously treat symptoms. In otherwise healthy individuals, upper respiratory, self-limiting, garden variety, seasonal cough does not require any specific treatment. Trust me, antibiotics does not influence the natural course of illness. There is a fashion, there is a pressure, there is a demand of society to put these patients on antibiotic. But we at IMA have taken strong stand against misuse of antibiotics and would urge all of you to refrain from using antibiotics for all those garden variety cases. Irrational combination must be avoided. And I like this Ketan's statement. Dr. Ketan Mehta used it in one of his slides, and he conveyed, do no harm. You may not be able to help patient every time, but trust me, just by irrational preparation, you may be doing more harm to the patient. Be aware of what you're prescribing. Many a times, the common brands that you are using may contain a lot of things which you are unaware of. And I have always requested all my friends to be aware of what combinations, what the preparation that you're using contains. It may be practically impossible for you to remember all compositions in detail. Please familiarize yourself with few of the preparations. Have that list ready in mind for dry cough, for wet cough with antihistaminic, for wet cough with bronchodilators if required. I'm sure that would help you and your patients. Thank you very much for your patient hearing.
Thank you very much, Dr. Agam Vora, sir. And it was a pleasure listening to you. I'm sure all of us have got a little extra knowledge because of your excellent talk. The next speaker is Professor Dr. Ketan Mehta, immediate past president, IMA Mumbai West. And we will take the question answers together at the end of both the talks. And to introduce the next speaker, I would request Assistant Director, CGP, IMA Mumbai West, Dr. Renu Budhwani.
Thank you, ma'am. Our second speaker, Professor Dr. Ketan Mehta, consultant physician, cardiopulmonologist, and diabetologist, present founder, president of Maharashtra State of Lipid Association of India, president IMA Mumbai West 24, 25, 22, 23, honorary general secretary ISC 2020 to 2025. Trust Board Member MMA 2020 to 2025 and postgraduate teacher for FCPS Medicine and ex-faculty KJ Somaya Medical College and many more, and above all, ever smiling and always helpful, our Dr. Professor Ketan Mehta. Over to sir.
Yeah, thank you. Thank you, Renu, for those kind words. At the onset, would like to thank IMA Mumbai West, Dr. Jayesh Lele, Dr. Rashmi Mehta, and the aspirant, my dear friends Manish and Dr. Gulshan, for this excellent webinar which has been planned for today. Are my slides visible?
Yes, visible.
Okay. So, friends, Agam has already given you a wonderful outline about the cough. But now he has given me, which you may not be aware, I have a deadline. He said, whatever you do, you finish off your presentation, but the Q&A should get over by 4 o'clock. I said, okay, done. So that is what now my thing is. Anyway, he has made the thing so easy because most of the things is covered by him. I would be specifically focusing on the dry cough over here. Of course, the standard way we know about the physiology, assessment of cough, pharmacology, and then there are certain dry cough case-based discussion and how to go about the approaches for dry cough management as per the ICS guidelines. Now, Agam has already spoken to you about the cough, which is not always a protective reflex, which we know it has a various causes. So though we say it is a protective mechanism, but at number of times we have seen that it could be an irritating issue and it is not always always a protective reflex. Now, he has very well elucidated about the physiology of coughing. I just want you to highlight on that when we talk about coughing, we know that there are three different phases of coughing. That is inspiratory phase, where air is taken into the lungs. Then you have got a compressive phase, where a glottis closes and the intrathoracic pressure they build as a result of expiratory muscle contraction, which is already said. And then third, there is a sudden release of air, which is happening at a high velocity, which is the expiratory phase. Now, why it is important for you to understand is because at so often we need to understand where is the problem, when and at what stage the coughing you are trying to stop, because sometimes the complications of coughing which happens due to the stoppage voluntarily or involuntary in a particular phase. Now we know the cuff which preserves the gas exchange function of the lung. What it does is it clears out whatever comes in the respiratory passage. So be it aspirate, it inhaled particulate matter, or there are secretions, or there are irritants or foreign body which have either entered, through the accidentally, or as an infection agent, or which has formed at the site of mucosal inflammation. So the purpose is it needs to be thrown out to keep the air passages as patent as possible. Now, I want you to have these numbers, which is so important. Worldwide prevalence of cough ranges from 5 to 40%, and in India, it is found 2.5 to 6% in rural and 1.7 to 5.4% in urban areas. Now, let me tell you, as a family practitioners, you all are seeing more number of cases of cough than either me or Agam would be seeing, because the prevalence of this symptom is so common. It accounts for 10% of respiratory referral to secondary care. That means as a consultant, we are going to see only those who are not being managed or not getting relief in the primary care. So it is very important for family physician to understand that the cough is in a detailed way, because it has a lot of implication and it has an impact in morbidity also. Now, Agam has already mentioned about the common causes of cough. I would be specifically talking about the adults. So, the common causes we know is the obstructive airway disease, which is asthma, COPD. Then you have got a bronchiectasis, COVID, as you know, COVID, which is now re-emerging again, coming up. But of course, we need to keep that in mind. When the COVID phase came in 2020, of course COVID-19, but in India we started in 2020 and 21. When anybody used to come and cough, what was your first diagnosis? COVID-19. Second diagnosis, COVID-19. And third diagnosis, again COVID-19. So you would think only as a fourth diagnosis something else. Believe me, at that point of time, me and Agam had discussed time and again, so many patients of asthma, acute attacks, and all was getting ignored, and they were just thought to be because of COVID, which may not be really the case. The other entities we know, drug induced cough, which Agam has already mentioned, GERD, again a very common conditions. In fact, the GERD presenting to the physician, family physician, and chest physicians also numbers or equal to those who are going to a gastroenterologist. So the presentation of GERD in the form of chronic cough is so common, which we must understand. Of course, there are inhalational toxicity due to the various inhalation of gas, vapors, fumes. Then there is a laryngopharyngeal reflux, which can give rise to coughing, lung malignancies, obstructive sleep apnea. Nowadays, of course, the awareness has increased and it can present as a cough, and of course, infective lower respiratory tract infections like pneumonia presenting as a cough also. Now, remember one thing: when you analyze the cough, it is very important to take a detailed history. And if the patient coughs in presence of you, it will give a much better clue, because there are different sounds, and that can also differentiate one from the other conditions. So you have like a brassy cough, which happens in especially intrathoracic tumors. Then you have a bovine cough, especially if there is a recurrent laryngeal nerve which gets involved in that. Whooping cough, which happens like a whoop, which happens in, of course, the condition itself, as you know, in whooping cough. Hysterical cough, which is again common in the young persons. I would not give a gender bias, but of course it does happen. Barking or croupy cough, especially in the patients with the croup, which happens. And the paroxysmal cough, when the here you will get a classical history. As the patient is about to lie down, he will start coughing. So, and when he gets in a sitting position, he will get a relief. So think of whether it is a obstructive airway like a bronchial asthma, or is he going into early acute left ventricular failure. So this will give you a lot of clue to that. So always remember, analysis of cough, listen to the patient's history, and once you have heard that, you will get so many clues out of it. And then you need to go for examination, physical examination, which is very very important. It will give us so much clue. For example, if you get a history of cough which is there in the positional ones, and if you get a wheeze, you know more likely you are dealing with the obstructive airway disease. Now, similarly, if you get this paroxysmal positional cough that is more in the supine position and relieved with sitting, and if you get a basal craps, you know you are dealing with the acute left ventricular failure. Of course, there are various tools for assessment of cough. These are visual analog scale called as VAS. Then there is a Leicester cough questionnaire, cough severity diary can be maintained, and a quality of life questionnaire which are there. So, of course, which may not be important in acute and subacute setting, but in a chronic setting, yes, it will have an important to see the response to therapy, which is definitely very important aspect also. Now, before we go to pharmacotherapy, again, Agam has already mentioned about the investigation, so I'm not repeating there. Investigations, remember, if it is a dry cough, it is of a short duration, acute history. For all practical purpose, you don't require investigations. So that is one thing which you will have to keep it in mind. You can directly, even in with your detailed history taking and physical examination, can come to the conclusion. Talking about the pharmacotherapy, as we said, there are two separate cups. So productive cough, Agam has already taken with. Non-productive cough, the purpose is, remember one thing: when it is a non-productive or a dry cough irritating, what should be the ideal cough therapy? You have to give antitussives. So antitussive is the one which suppresses the cough reflex. So, and which are the ideal antitussive? Which suppresses the frequency and intensity of cough without affecting normal elimination of secretions. So you want, if at all there are any secretions, it should get eliminated, and it should not affect it. So that is what we are looking as a ideal antitussives. Now, again, you should be knowing that for a dry or a non-productive cough, when you look at the cough formulations, there are various formulations are there. Remember one thing: do not club expectorant and suppressant together. It is absolutely irrational. So be it any compound which is having a product or mucolytic or has got an expectorant property, should not be clubbed with any suppressant therapy. So for a dry or a non-productive cough, always the suppression should be used. Of course, you can use adjuvant antihistamines which can give some added benefit. So that is the most important point when you are choosing the right type of cough syrup. And as you know, recently the government has banned so many irrational formulations which you will be aware about it. Now, we know the cough is so easy to treat, but at the same time, it is a difficult, which has got some challenging things to face. So, as a clinician, you face challenge. First, you need to identify the correct etiology. So, when you are dealing with or treating the cough, it is not you are giving the patient relief of that one symptom, but you must identify what could be the cause of this cough. Is it allergic bronchitis? Is it early acute left ventricular failure? Is it drug induced? So that you need to do it. Of course, if you cannot do from history and physical examination, then you need to come for diagnostic evaluation. There are various tests which Agam has already mentioned. Again, you can't make use of each and every test. So you need to identify and pick up what is the right test for which subject, and that will help in giving the diagnosis. And finally, then you need to treat the primary cause. That is the most important. So again, point of importance over here is that when you are treating cough, it is not at all necessary to treat with antibiotics. In fact, it is, people think that cough is because of lack of antibiotics level in the blood. So please do not treat it. It should not be treated. There are very, very rare circumstances where a dry cough would need antibiotic also. So that is the most important point. Now let's look at certain case scenarios. This is a 34-year-old man presented with history of dry irritating cough since 1 week. He is unable to sleep at night due to the irritating dry cough. Had a history of cold 1 week ago. No other significant medical history. No history of COVID-19 infection. Had taken 2 doses of vaccine. And personal history wise, he's been a non-smoker. Now, this is very, very important, especially you are taking eliciting history for a coughing. You need to know history of smoking. And very important point is that, just don't ask casually, do you smoke? He might say no, he doesn't. Or do you take cigarettes, or do you take bds? He might not say yes, because now you have got a e-cigars also available, which he will not consider, or that you are asking about it. So for him, it is very important. So you need to ask the history in detail about it. So now coming to this patient, what is the type of cough? As he has mentioned, it is a dry cough. Any clue from the history? Yes, had a common cold 1 week ago. Any specific examination finding? Nothing abnormal detected. Respiratory system was completely clear. Hemodynamics stable. No tachycardia, no tachypnea. Any investigations required? None. So, what is the clue? Now, the clue is in the history itself. Now, this gentleman had started with a common cold 1 week ago, and now he has got a cough. So, this cough is following an upper respiratory virus infection. It is called post infectious cough, and it is so common. Now, you must have seen, even when he had a respiratory viral infection, he might have coryza, mild low grade fever, body ache, which would settle down in 5 to 7 days. But the post infectious cough can persist for weeks together. And how long this can persist? Up to 8 weeks. So remember that, these are the subjects. You must have seen classically during COVID time. Even in COVID time, we had seen the acute symptom settles down within 1 week. But what happens subsequently? He has a cough which is a little different type of cough than what he had during the acute infection, and that is called as post-infectious cough. And again, a very, very common entity which is there. So, what is the approach to diagnosis? So, in case of dry cough, you need to look out for what could be the common causes of this dry cough. So, as I mentioned, check for the history of viral infection or what had happened a week ago prior to the onset of these symptoms. Second point is post nasal drip, again a very common condition. It, ask the subject if he is feeling mucus dripping down the throat, or he will say yes, there are continuously irritation in the posterior part of the throat, he can feel something dripping posteriorly. So you need to check for it. Symptoms of reflux, you need to check, and hoarseness of voice. So especially you check with the patient that do you get sour irritations at night, or when you lie down immediately after the food, or do you feel the symptoms of acid peptic disease. So these are, if they are having it, they would this could be because of the gastroesophageal reflux. And sometimes they say for acidity they take medicine what we call as proton pump inhibitors, and they get relief in cough. Now that's a very classical diagnosis. So if they get a relief with the PPIs, it is nothing but the GERD. Then Agam has already mentioned we need to elucidate whether there is a history of any drugs which can cause cough, like AC inhibitor. You have got a ramipril, captopril, lisinopril. All these prils are known to cause a dry irritant cough. Again, you need to look for the positional cough worsening at night, and I have said crackles on auscultation. So remember, cough is not only just a presentation of a respiratory system involvement. It could be because of the could be a manifestation of the cardiac condition also. So which you should keep it in mind and not to miss that. Okay, let's come to the treatment approach. So you have a specific treatment, and then you have got a non-specific treatment also. So specific treatment will determine what is the cause of this. So suppose if you find that it is because of acute left ventricular failure, you need to start the therapy accordingly also. So there is an entity what is called a smoker's cough. So we know that it is not because of they have developed yet COPD, but it is the constant irritation of the air passages due to the smoking and the inhaled products. So the therapy of it is smoking cessation, and smoking cessation has to be in fact, not only that, all patients, for example, those who are COPDs or those who have allergic bronchitis, and if they are smoking, if you don't tell them about the cessation of smoking, they will not get relief, and tell them that they will have recurrence of symptoms. Antibiotics when to be given, of course, which has been covered by the in the previous presentation. Remember one thing: unless it is a bacterial upper respiratory tract infections, then and then only you will treat with antibiotics. Otherwise, you don't need to treat with antibiotics. Now let's come to symptomatic treatment, or what we call as non-specific treatment. Expectorant if it is a productive, and suppressant if it is a dry cough. So for our subset it will be a suppressions we have to be used. Paracetamol can be used judiciously as and when required. If there is a fever, body ache, all viral fevers, you need to use paracetamol at that point of time. But of course, you need to use for limited period, obviously not using for more than 5 days. I would say avoid use of NSAIDs at that point of time, which is important. Antibiotics, as I mentioned, you need to avoid in most of the cases. And for uh, wheezing, or whenever there is a bronchoconstriction, wheezing is a marker that there is a bronchoconstriction. And the best therapy is inhalational therapy, be it a dry powder, be it inhaler therapy, be it a nebulizer therapy, but you need to use. So unless you use those inhalation therapy, he will not be relieved over there also. Now, as I said, for dry cough, we need to choose the cough syrup. So how do we go about it? So we need to see, is there associated breathlessness and dyspnea, or no dyspnea or hemoptysis. So if there is associated dyspnea, that means there is a possibility of bronchoconstriction or bronchospasm. That means we need to use the syrup with a bronchodilator. So that is, we have got lot of bronchodilators based syrup available: salbutamol based, levosalbutamol, we've got a terbutaline base, so on and so forth, but we need to use that. And if there is no dyspnea, then we need to use a suppressants like dextromethorphan preparations also. So let us understand about these antitussives, which we use it for dry therapy. It acts at various levels. So site of action is either it can be acting at the central cough receptors, or it could be acting at a peripheral irritant receptor. So these are the two mechanisms, and why it is important for you to understand, because the side effect of the syrup which you are giving depends on where this syrup or medication is acting at. So, if you talk about the peripherally acting antitussives, we know levoclopicerastin, benzocaine, benzyl alcohol, phenol, turmeric in the form of lozenges. Then there is a lidocaine or xylocaine, which is used locally, especially during bronchoscopy. And then there are local sialogs, which are a soothing, as Agam also mentioned, certain home remedies are there. Now, when we talk about the centrally acting antitussives, what does it do? It acts at the central level. It suppresses the cough by raising the threshold necessary to stimulate the cough center. So, there is a threshold level, and if that threshold is set at a higher level, the person will not get so easily cough. But at the same time, since it is centrally acting, the side effect, which is in the form of sedation or hypnotic effect, which will be seen. And that's how you must have seen all the cup syrups which you commonly use, which are centrally acting. The common side effect is sedation after taking the drugs. In fact, you should be taking, if they are taking centrally acting antitussives, they should not be driving the vehicle, they should not be taking or using any machines which is in the industry, because that can lead to or can meet with an accident. Now, again, centrally acting antitussives could be narcotic or a non-narcotic. Narcotic are codeine and flocodine, hydrocodone, and hydromorphone. And non-narcotic are dextromethorphan and noscapine. So, which are things which you must understand. Now, quickly look at another case. Now, this is a 54-year-old female presented with dry cough which persisted for 3 weeks. It's a non-productive cough occurring throughout day and night without any associated chills, fever, or other systemic complaints. Personal history wise, non smoker, occasional alcohol user, no recent travel history. So, here, what is the type of cough? It is a dry cough. Clue, yes, it is a 3 week long. You think this could be an infective cough? Person would have gone down if you have not treated this 3 weeks long cough with specific therapy. So it is not an infective cough. Examination finding, nothing abnormal detected. CBC was done, X-ray was done, which was normal. So what is the clue over here? So you must remember here, let us before that learn subacute dry cough, which could be likely post-viral in etiology. And this I have already shown in the previous case. So this lady was started with dextromethorphan 15 milligram every 4 to 6 hours, and depending on the need for cough suppression. And of course, you need to counsel the subject about avoid irritating, staying hydrated. Now that's very, very important. Hydration, hydration, and hydration. A key message, especially for a coughing, because it would the dry, especially this dry cough, will get worsen if the hydration status is poor. They need to use humidified air, which can also give them relief from the cough symptoms. And believe me, friends, the various societies, be it EMA, ACCP, that is American College of Chest Physician, German Respiratory Society, all of these are recommending dextromethorphan in both acute and subacute phase. So we have seen the first one where acute, here it is we are almost coming to subacute phase. Now there are recommendation from Indian Chest Society about the non-pharmacological approaches. That is hydration, which is, as I already mentioned, lifestyle modification about education, behavior, certain speech therapy. We need to especially inform those who have a GERD, they should not lie down for 2 hours after taking a main meal. So especially if those who are taking late dinners, and if they have a GERD, they are likely to have this cough. So please tell them that they should have early dinner, so that at least there is a gap of 2 hours before they go to bed. Then, of course, maintaining the good laryngeal hygiene, certain breathing exercises, and counseling them would be, especially avoiding certain irritant foods, will definitely be helpful also. So, as per this Indian Chest Society, what are the approaches for dry cough management? Again, they mentioned dextromethorphan, which reduces cough significantly as compared to codeine, because what we are worried with codeine is a side effect. We know that, and psychotomimetic effect or respiratory depression, which can also come up with codeine if the dosage goes up. It is effective in reducing cough intensity and nocturnal awakening in both adults as well as children also. So that's why it is also considered as suitable for in all age groups. And at a therapeutic dose, it has a quick onset of action, that is within 15 to 30 minutes, and the duration of action is 5 to 6 hours. So on an average, it is to be taken 4 times in a day. It is the preferred antitussive even in pregnancy and lactation. Now, this is very important because as a family physician, you may come across a lady and they commonly first time will come to, and you can't tell them because you have a pregnancy, you go to gynecologist. It is you will have to treat it. So remember, if you have to prescribe antitussives, dextromethorphan is a safe, and it is recommended for the short-term symptomatic relief of coughing, and when other therapies have no effect or have failed, which you can give it. So that is, we have got a beautiful alternative for codeine, which is there. Now, does your patient need to come for follow up? So, follow up is required only if the cough persists. And again, you must remember red flags, what Agam had said. So, if they have got a fever which is persistent or weight loss, so even with the dry cough, they could be having CA lung or tuberculosis. Or if they have a hemoptysis, again, those two differential will come in the picture. Or there are associated breathlessness, which could be because of heart failure or obstructive airway disease, pulmonary fibrosis, or inhaled foreign body itself also. And there are breathing techniques which they need to follow, which will definitely can suppress the cough. And these are, you take ask them to take a diaphragmatic breathing, which has been shown, slow deep breathing, which will also be helpful. Then there is a post lip breathing, so breathe in through the nose and breathe out from the mouth. And then certain yoga techniques which will help, because pranayam and other things will improve the lung capacities, and the cough reflex can get altered because of that. So this would definitely help, especially for people who have a long standing symptom of cough. So friends, we know cough is so easy to treat, but at the same time it is difficult, and we need to take into consideration various parameters. And that reminds me a beautiful quote from Albert Einstein, that not everything that counts can be counted, and not everything that can be counted counts, and which is so much true when we talk about the cough over. Thank you so much for your patient hearing. And since I have finished in time, so we have the privilege of Agam Bora with us for taking Q&A.
Thank you, Dr. Ketan. And we definitely have questions. I would request Program Coordinator Dr. Jayesh Lele sir to conduct the question answer session.
And first of all, thank you, Dr. Agam and Dr. Ketan. Most dependable our professors, and I'm sure they have done the justice to the topic. Some questions are, I think, common. Some questions I feel they are more towards for the Dr. Agam and I think. Only one question it comes to my mind is that, whenever Agam says it's a productive cough, and when Ketan says, this is a dry cough. It is possible that in a day, suppose a person is coughing a couple of times, and at times the person may be bringing out some kind of a sputum 1 or 2 times, and rest of the times may be more. So, what will be the criteria, or what will be the line between the product you cough and the dry cough? How will you label that this is a dry, this is a cough? I mean, that you can just
Absolutely fantastic question, sir. This is a very routine dilemma that we all see in our practice, whether to call it dry or whether to call it wet. Trust me, airways does not produce any secretion in normal situation. So in normal situation, you and me don't produce any expectoration. Still, somewhere around 30 ml per day of expectoration is considered acceptable or it's considered normal. So anything at about 30 ml would be considered by and large as a dry cough. Any cough which has got little more than that would be a wet cough. Having said that, any cough, even if it has got little bit expectoration but it is thick, or any expectoration which is greenish reddish, would be considered as a wet cough. Everything otherwise would be a dry cough. And whenever possible, especially dry cough, one must avoid treating it. Wet cough, you may require symptomatic treatment. Dry cough must be avoided, or if at all, must be treated with demulcents and what local preparations and steam inhalation and what Ketan said, some exercises, etc. The dry cough must only be treated if it is associated with complication. The most of your complications will be associated with dry cough. So you have this syncope happening, or you have this pneumothorax is happening, that would be generally seen with dry cough and not with wet cough. But that's a good question. Thank you.
Ketan, you want to add some?
Yeah, so Agam has rightly said. So, quite often we just say that cough with scanty mucoid expectoration. So, if that is scanty, what Agam was just mentioning, a very minimal or comes out occasionally also. But whenever that is there, as rightly said, for most of the time it is always dry when it's a normal situation. But even if it is a mucoid or very scanty, we would not be considered taking it as an infective cough. Now, what is most important is we must take into consider most of the time the upper respiratory tract infection when we talk about is by and large will have a dry cough, and lower respiratory tract infections are by and large are productive of. Now, this is a general. It always follows the same trend, but majority this is how it is differentiated. Now, the point is we must know what is the cutoff level. Where do we call it upper respiratory and where do we call it a lower respiratory? So, in the respiratory tree, it is considered from the level of vocal cord. Anything above comes upper respiratory, anything below comes as the lower respiratory also. So on that basis we get some clue also. So by and large upper respiratory infection would be with the dry cough will be predominant, even if it is infected predominantly viral, which is more common than the bacterial infection. Thank you.
Suppose variant asthma without rhonchi in the chest. I think this is Agam would be a better person to. Yeah.
Agam is always a better person, sir. No question.
Always.
I refuse to accept that statement. Okay, you could get it is not uncommon for us to pick up asthmatics without any rhonchi. So there would be two situations. One, it would be when in acute exacerbation state, where chest is completely silent, but you will have all other signs of asthma. You will have accessory muscles in use. Patient would be extremely breathless. There may be hypoxia and something what we were told is status asthmaticus. So in those stage, spasm is so tight that there is no appreciable rhonchi. Of course, we will not come across that situation common. Most of the time, we may have situation where patient is sitting in front of you, but and clinically or history wise, this could be asthma, but chest is silent. You could get that, and this could be cough variant asthma. Patient generally presents only with dry cough. You will you will be able to make diagnosis of asthma only if you investigate these patients further. Investigations would have a simple CBC where you may have eosinophilia. It may have atopy workup where you may do IgE. It may have X-ray sinuses where you may look at the polyps, and then it would need a spirometry where you have obstructive pattern. And the most important thing is therapeutic response. When you put them on a salbutamol puff and maybe repeat the spirometry maybe 20 minutes down the line, you will be able to appreciate improvement. Many times children have this. A lot of children, they have exercise induced asthma, or at least the asthma which gets worse during exercises. So they will have these symptoms only when they run jog in the school, and when they come to you in your clinic they may not have this appreciable bronchi. So this could be the. Thank you.
So Ketan, these are nowadays.
So we lost you. Can't hear.
No?
Yeah.
Can you hear? Yeah.
Yes.
Yeah. Can we give expectorants containing sodium and potassium to heart failure patients, or are there any drug interactions, or does the expectoration syrup containing sodium potassium are contraindicated during the heart failure treatment procedures?
So, sir, first and foremost, let me tell that patients who are coughing with the heart failure do not require cough suppressant or cough expectorant therapy. They need to be treated for their cardiac failure point of view. Now, why does this happen? Because there is a pulmonary congestion. So where we have got increase in pulmonary capillary wedge pressure, so there is an extravasation, so the fluid which is there in the lung parenchyma which is causing the coughing to happen. So what is required is they need to be given adequate diuretics. So diuretics, they will only and only respond with the diuretics. So the moment the pulmonary capillary wedge pressure goes down, so the moment the pre-volume reduces, they will definitely start feeling better with their symptoms of coughing. So that is what we were mentioning about history taking is of utmost important. So all patients or who are presenting with coughing need not always go to Agam. They might have to come to Ketan also, because
And I don't like it at all.
and that is very very important, because that is it. So that is one thing. And please do not, even if they are coughing, they do not require. In fact, I would go one step ahead over here. There has been a data, the people who come, they will come with the expectoration, wet expectoration, which is there in pulmonary edema also. Again, at that point of time, they do not require antibiotics also at that point of view. In fact, the data which has shown that with the patients with acute left ventricular failure who presented and were given antibiotics when it was not needed, there was a higher rate of morbidity and mortality. So that is sometimes overdoing can be dangerous also. So that point needs to be kept in mind. Thank you.
Okay, Agam, in COPD, when do we give expectorant, and when cough suppression agents, how do you decide what to give?
By and large, cough suppressant and expectoration both will have to be avoided in COPD in a routine situation. But yes, there would be compelling situations for you to use it. Suppose if you have a patient of COPD, coughing, and has got dry cough, by and large, this cough would settle down with the aerosol that you're giving. So this patient comes to you probably since there is a mild exacerbation. Mild exacerbation needs to be managed with the changes in the pharmacotherapy. Suppose if you want to prescribe cough suppressant only in situation where one, patient is unable to sleep, two, patient had got cough complication like maybe syncope, giddiness, or maybe there is urinary incontinence during that time. So as Ketan mentioned in his slides, you must use this suppressant only to suppress the excessive cough. Don't suppress this cough completely. Expectorant, suppose the patient has got very poor cough reflex and is not able to bring out those sputum, and if you give them expectorant, they may actually drown themselves. So they must be given good postural exercises. They must have a good cough reflex for you to use mucolytics or expectorant. I use expectorants or mucolytics only for a very short period during exacerbation, and by and large when I'm supervising them. I don't like to give them at home when they're unsupervised or when I'm not too sure of their good cough reflex. But otherwise, depending on the need, with this care, you could use whatever required.
Dr. Ketan, in CAD patients specifically with asthma, can we give bronchodilators?
Very good questions. So, the bronchodilators, when you have to give it, it would be first mode of therapy is inhaler therapy only. So that is the one thing which I think there is some inertia at the family physician level. So which is not starting. In fact, the safest mode of therapy or delivery would be the inhaler therapy, be it a dry powder, be it in nebulizer form, be it in an inhaler form. But that is the one. In fact, the oral preparations tablet, which is available with the therapy in terms of you have a preparations of salbutamol or you have got darbutalin and all. In fact, those are absolutely on the downward trend, especially to uses, because we have seen most of the patients do fantastically way with inhaler therapy. In fact, let me tell you that we do use those drugs, the beta 2 agonist group, for people who have got a Brady arrhythmias, or especially when we want to increase the heart rate, that is the time only we have been using orsiprenalin or terbutalin, which we use it, but not for the relief for asthma point of view.
So I want to add, sir. So what Ketan said. So if you have a CKD patient, you are worried about two particular things. One is heart rate related complications, so tachycardia, etc., and second is potassium. So beta agonist can give you beta agonist in the sense whatever you're using, salbutamol, terbutalin, etc. All that can play with your potassium. So you may have to monitor potassium little more frequently. Rest otherwise if required. And so far as nebulized medicines or aerosol medicines are concerned, you need to use them. And when it is steroids, inhaled steroids, absolutely be as liberal in using it as the need be for the case. There is no contraindication on using inhaled corticosteroid for asthma.
I think Agam and Ketan, made it very clear for the family physicians to use the inhaled medicines, whether it's a bronchodilator or with the, as you mentioned, a mild dose of steroids. The inhaled medicines, because yes, definitely, the patients, we need to encourage them continuously that yes, this is going to be a very handy tool with them. They can carry anywhere, especially when they're traveling or anything. And a small tool in their purse or kind of a bag, it will be very fitting and very important. Dr. Agam, regarding the sputum color and consistency, helpful in distinguishing between the bacterial and the viral cause of bronchitic cough. In practice, I don't know. I think it doesn't. Your
Absolutely correct. So by and large, when I was a student, I was told that you have different colors giving you different idea about bugs, but I think that does not hold true anymore. Any secretion which is retained in chest for a longer time will be greenish in color. So typically your COPD patient will tell you early morning sputum is greenish, yellowish in color, but as day passes, probably it becomes thick mucoid or even mucoid. So that's not infection. So you would not take single symptom into isolated understanding. So you have a patient who's got cough, who's got chest pain, who's got fever, who's got difficulty in expectorate, who's got symptoms which are worsened over a couple of few days, and then when he's telling you about greenish or yellowish sputum, yes, then it would mean infection, but otherwise just a single early morning greenish sputum would not mean anything. Having said that, if there is thickening of sputum and discoloration of sputum, for all practical purposes in COPD it is considered infection, but otherwise in healthy patient it may not be infection. Generally, you have rusty sputum, which may mean streptococcal. If it is a jellic, and it would mean Klebsiella, but you can't differentiate it quickly. It would make you suspect those bugs. Viral and bacterial cannot be differentiated on sputum color. Thank you.
when you recommend stepping up from expectorant to mucolytics and hypertonic saline nebulization, or especially in pediatric cases, I think that will help many family physicians, because they just add sometimes some combination of just simple expectorant and then wait. But then, especially this today's we are the days of the specialty kind of a medicines, and we have different kind of expectorants and the mucolytics available. So when to differentiate and when to use them?
So mucolytics are by and large N-acetylcysteine group of drugs. So whenever there are thick secretions and there is a need for breaking those tenacious into little, making it less viscid, etc., you would use N-acetylcysteine. And expectorants are mainly to, by and large they do the same work, but expectorants are mainly to bring it out easily, to facilitate expectoration of those particular things. There is no particular situation where you have to use one over the other. But what I do is, whenever I find patients of COPD have got thick secretion, they're unable to get it out, the first thing I would do is give them hydration. Many times it is the sign of dehydration. So, and with adequate hydration, and we may tend to miss that, there is significant insensible loss of water. So when patients are breathing, your COPD exacerbation is sitting in, then breathing like this, there is so much of water loss. If you just replace this water, most of these expectoration, they find it easy to bring it out. If that does not happen, you would consider what you said, sir. So if I have to induce sputum, say in the hospital, I want a good sputum for culture, etc., I would use your what you mentioned about 3% normal saline or something called as hypertonic normal saline, which would also induce sputum and would make it easier for patients to get it out. And mucolytics, I would by and large consider in this is my way of looking at it. I would consider mucolytics even if there is infected sputum, but expectorant I would prefer when there is non-infected sputum. I mean, that's just the way of differentiating these two situations clinically.
The specialty of mucolytics adding in a when you are on the asthmatics, especially whether mucolytics will help asthmatics to prevent the frequency of bronchial asthma attack, or
No,
kind.
sir.
No,
No,
yeah.
sir. The mucolytics, etc., in asthmatics, by and large, has got no role. But having said that, if you want to use it, please use it during only those exacerbation days. Say maybe 3 days, 5 days, short term. They have absolutely no role on a long term basis. On a long term basis, only inhaled medicine with your dual drugs. That means your two drugs, beta agonist and steroids. So you have those salbutamol, levosalbutamol, salmeterol, formoterol, anything from beta agonist, and any steroid, beclomethasone, betamethasone, now you have fluticasone, whichever steroid you're using, combination of these two is must for your asthmatic patient. And don't be in hurry to stop it. Continue it for a longer duration, maybe lifelong. And you would use, if required, the first add-on drug to my mind will be montelukast. So you may think about adding montelukast, levocetirizine, or any other antihistaminics. And if they have exacerbation, short period of mucolytics or a short period of your phosphodiesterase inhibitors, that means your derifilin, your aminophylline, your whichever filin preparation you give, I would give it only for a shorter duration. Thank you.
Sir, I would
You
add.
want to add something?
Ha,
Yeah.
sir. So when you mentioned the question which came for how do we prevent for the during an or rather for an asthmatic the episodes or anything, I would say they have episodes because of infection again and again. And the most important point from family physician is to create awareness that these are the patients who require yearly influenza vaccination. Our president has already worked on it at national level, at the branch level also. So look, now Agam is already so much well got into it. So I think that vaccination is the one thing which we should strongly recommend. As a family physician, we must tell all our asthmatic patients to go for annual influenza vaccination, which is the must for them, the must.
Ketan, I thought you would add something about diet, also your favorite topic. Any particular diet you would want to recommend, whether it makes any changes in, sputums or etc. Would you want to come?
So, correct. So, again, in that, the most important would be hydration, which I already mentioned also, which needs to be, which will keep if there is a mucus plugs or anything into liquid state, that would be one. Second point is these patients require a lot of high protein intake. So, be it asthmatic, be it COPD patients, be it interstitial lung disease, they would require a good high proteinous nutritious diet. That would be one thing. And they need to curtail on the carb. Now that is one thing. So even if they are not I mean, they may not be diabetics, but the carb needs to be reduced. That is the one important point which needs to be taken care of. Thank you.
Yeah, thank you, Dr. Ketan. And the last question is definitely for the Agam, because we have heard about the air purifiers from Agam a couple of times, and So I would request Agam to give just a small note on the air purifier, especially. Maybe for asthma, maybe for COPD, or maybe especially the
In general.
morbid,
Okay.
morbid patients where they have some problems and the air purifiers in the house. Hospitals, of course, they use, but in the house or the consulting or somewhere, I think your choice, please.
Sir, air purifier definitely adds value to it. Unluckily, we don't have any studies which talks about its superiority, but in practice, I would definitely recommend to use air purifier. Now, air purifier is available with multiple technologies. You have ultraviolet purification of air. Generally, it is not required for common use. It is only required for, like I have in my clinic, I would have all three technologies together, but only infected places, healthcare providers, etc., would have ultraviolet purification. There are other two technologies available, which is one is filter technology or the HME filter, and second is ionizers. There are certain mechanism by which the ionizers take the positively charged particle, binds with it, makes it thicker, and brings it down to the floor. So that means they are not anymore air borne. And the HME filters is the filtration of because there is air filtration going on. For air filtration, there is to be adequate movement of air in the room. And for HME filter will not work if it is closed room, if there is hardly any movement, and the ionizer would work in that situation. So depending on the situation, depending on what is the area of your cabin, depending on how many people move in that cabin, what is the cross ventilation, it's like you asking for air condition. You may ask for half a ton, 1 ton, 2 ton, depending on the usage, depending on the area, depending on number of people, air transfers. Similarly, various things need to be taken into consideration when you decide about the capacity of that air purifier and the technology behind it. So there are 7 different types of air purifiers available, commonly used as this three. And the places like we are all doctors, so we need to have air purifier with ultraviolet filtration and either HME filter or ionizer, whichever is routinely available. The ultraviolet does not require any maintenance. HME filter require those filters to be changed every year, and that it has got a decent cost. Ionizers again are maintenance free. That's it. Thank you, sir.
Any more questions?
You have to.
Yeah.
I thought Ketan wants to say something.
Yes, Dr. Ketan.
Don't treat me. That's the message.
So I think today's session has proved that any CME conducted by IME Mumbai West is no less, is at par with any teaching at any of the medical colleges of the city. And we are proud of it. And our speakers today were equivalent to HODs of some medical college department speaking, and everyone has enjoyed it. I would request Joint Secretary IME Mumbai West, Dr. Bhavna Patel, to give a vote of thanks.
Thank you, President Dr. Rashmi Mehta. I really think it reminded me of my college education, because the way they have taught us today, I would say they have taught us today, it was really very, very much required, and they have covered everything. I'm thankful to pulmonologist Dr. Agam Vora sir and consulting physician Professor Dr. Ketan Mehta sir, our esteemed speakers, in spite of their busy schedule, that they have spared their time, valuable time for us and sharing their knowledge with our members. The commonest disease, and that is cough, a very good way to analyze it, to approach to the diagnosis and differentiate between a dry cough and a productive cough. The proper history taking, the detailed clinical examination, come to the diagnosis and just see that it may be a manifestation because of some other problems. So thank you very much. And they have shown us the importance of pharmacological treatment as well as non-pharmacological approach. I am also thankful to Dr. Manish Verma from Spiron Company for arranging this webinar for us. Thank you very much. Thank you, our dear Dr. Jayesh Lele sir, for being a moderator for today's function. And thank you all the attendees today who have definitely attended and learned a lot from our esteemed speakers. Thank you.
Thank you, Bhavna. Dr. Manish, thank you so much for trusting once again on IMA Mumbai West and all our esteemed speakers. And of course, we look forward to have the second session. We have already given the tentative date. So you can let us know, and Dr. Rashmi would be there to guide us and implement it at the next CME program. Yeah.
That's a pleasure, sir. I would like to thank everybody, the speakers, Dr. Lele and Dr. Rashmi, for your kind words and the excellent presentation. And a very great thanks from Spirent and DRL, who are the sponsors of this program, sir.
Thank you very much.
Thank you.
Thank you. Yeah.
Tavish, we can stop the streaming.